In this video, we are discussing about traumatic urinary bladder rupture.
Urinary bladder is a muscular reservoir of urine, interlacing fibers of smooth muscles and which is lined by urothelium, that is transitional epithelium. The important area in the bladder is the trigone, that is a triangular area where there will be ureters are opening at the posterolateral angle and urethra will start at the inferior angle of it. In this picture, you can make out the trigone of the bladder very well. The urinary bladder is supported by the fascia and ligaments, so pubic-vesical and pubic-prostatic ligaments. Pubic-vesical is anterior and lateral condensation of the fascia, so that will get attached to the pubic bone, and pubic-prostatic is the condensation of the fascia anterior to the prostate and lateral to the prostate will get attached to the pubic bone. And there are ligaments, that's a median, medial and lateral ligaments. In the diagram, you can make out pubic-vesical and pubic-prostatic ligament. In this diagram, you can make out the superior ligaments. It's a median umbilical ligament. So that is found. That is a remnant of urachus. Medial umbilical ligament, that is obliterated umbilical arteries, and lateral umbilical fold, which contains inferior epigastric vessels. So about the sphincters, internal and external sphincters. Internal are lined by smooth muscles, that is at the neck of the bladder, and following relaxation of it, their micturition will happen. And the most important function is it prevents the retrograde ejaculation. And the external sphincter, that is a striated muscle, it's a horseshoe shape, that is just distal to the prostate, and it is a voluntary control. Arterial supply is by inferior and superior vesical artery, which are branches of internal iliac artery, and venous drainage takes place into the internal iliac vein. The lymphatic drainage is through the internal obturator and external iliac lymph nodes. The urinary bladder innervation by sympathetic, that's T11 to L2, and parasympathetic by S2 to S4 through the pelvic splanchnic nerve. The important thing is the distal sphincter, which is supplied by the pudendal nerve. Coming to the topic proper, the rupture of the bladder are mainly due to the blow or kick or fall, road traffic accidents, stab and gunshot injuries, endoscopic trauma, diathermy, instrumentations, and following surgeries. Coming to the types of bladder rupture, intraperitoneal, extraperitoneal rupture. So remember, the rupture of the bladder are two types, intraperitoneal, extraperitoneal. So intraperitoneal rupture is around 20%. That happens when there is a blow, kick or fall in a distended bladder or during surgical procedure like TURBT, that is transurethral resection of the bladder tumor. The clinical features are severe abdominal pain, abdominal distension, no desire to micturate, sometimes with syncope and shock. When it is contaminated urine, patient may develop rigidity, guarding, that is peritonitis. Once you suspect bladder rupture, so when you do a plain X-ray of the abdomen, that's an erect position, it will look ground glass appearance due to fluid in the peritoneal cavity. Intravenous urogram, that will confirm the leak, and when you do retrograde cystography, that will confirm the diagnosis. The initial basic investigation, invasive abdomen pelvis will tell you the free fluid in the peritoneal cavity, and CT scan again is one of the confirmatory tests. So this picture showing, that's a cystogram showing urinary. So once you diagnose this intraperitoneal bladder rupture, the treatment is surgeries. Either can be done by laparoscopic or open. So in both method, the idea is to identify the ruptured site and suture the ruptured site with a single layer technique or 2 layers using absorbable sutures. So while repairing the bladder, never use non-absorbable sutures, and catheter, urethral and suprapubic catheter has to be placed. Coming to the extraperitoneal rupture of the bladder, it's 80%, and this happens when person falls or gets accident in a non-distended bladder, and also seen during transurethral resection of the prostate. The clinical features are fullness of the lower abdomen, diffuse pain, inability to pass the urine. On examination, there will be tenderness in the lower abdomen, with sometimes you will see the blood in the external urethral meatus. So when you do the plain X-ray, most of the time you will see the fracture of the pelvis, and the cystogram will show the leak, and CT is again confirmative modality of the imaging. The treatment for extraperitoneal rupture of the bladder is most of the time it is conservative by placing urinary catheter drainage for up to 10 days. Sometimes the conservative treatment may fail due to the blockage of the catheter due to the blood clots. In such cases, you have to do the cystoscopy, remove the clots. If that also fails, then surgical intervention may be necessary. So rupture of the bladder during operation, so that can happen in inguinal, it's a sliding hernia, femoral hernia repair, during hysterectomy, during pelvic surgeries. The main idea in this scenario is identify the injuries or rupture, then repair it, put a catheter for up to 7 days. Sometimes there is a chance of missing the bladder injuries, and later patient will present with severe abdominal pain, not able to pass the urine. In such cases, identify or confirm the diagnosis and treat as similar to the rupture of the bladder. So when there is a extraperitoneal rupture during endoscopic resection of the prostate, in that scenario just put the urethral catheter, drain the bladder, cover with antibiotics. So at the end, remember 2 types of bladder rupture: intraperitoneal rupture, extraperitoneal rupture. Intraperitoneal rupture, surgical modality is a treatment of choice, either by laparoscopic, laparotomy. It's repair, bladder drainage, and put the urethral catheter. Extraperitoneal rupture, it is conservative. It is urethral catheter drainage for 10 days if fails endoscopic or surgical intervention. So the complications following rupture of the bladder are cystitis, pyelonephritis, peritonitis, pelvic abscess, fistula formation like vaginal, rectovesical, paralytic ileus, hemorrhage. So the complications following rupture of the bladder are cystitis, pyelonephritis, peritonitis, pelvic abscess, fistula formation like vaginal, rectovesical, paralytic ileus, hemorrhage. So because of these dangerous complications, it is always better to identify the rupture of the bladder and treat as early as possible. Thank you.